Every lecture you are watching in here is pushing you to one step closer towards your USMLE dream, and also residency in USA, say it a neurosurgery, internal medicine, or whatever your dream is. These lectures are pushing you a step forward. So welcome back to Not So Complicated. We are doing pathology USMLE first aid line to line series. In step 1 we have completed our general principles, we have completed our cardiovascular system, respiratory system, and hematology and oncology portion. So today we are beginning our gastrointestinal pathology, and this is a very huge topic, so we are covering it up in 3 sessions, and today it probably will become a session of 1 hour. So stay tuned, grab your cup of coffee, let's begin. So we begin from oral pathologies, right? Oral pathologies, any deformities or deviation from a normal physiological features in our oral region is oral pathology. Obviously there are certain symptoms like aphthous ulcers, squamous cell carcinoma, and sialolithiasis. Everything that has sialo in it is of salivary gland. Sialolithiasis, sialidinitis, and then salivary gland tumors, right? So basically, what are aphthous ulcers? These are also called canker sores. These are also called canker sores, right? So most common oral lesions that appear is painful, shallow, round to oval ulcers covered by alloys exudate is there. So there is alloys exudate in there. So here is a figure. There you can see that is a case of ulcer, aphthous ulcer or canker sore. And then it is a case of recurrent aphthous stomatitis, is associated with celiac disease, which we will talk later. IBD is inflammatory bowel disease, SLE, systemic lupus erythematosus, Beckett syndrome, and then HIV infection, right? So that is about aphthous ulcers. And in squamous cell carcinoma, this is the most common malignancy of oral cavity. So if somebody asks you what is the most common pathology or malignancy of oral cavity, that is squamous cell carcinoma. It is usually affects the tongue, associated with tobacco, obviously, because it contains carcinogens and like nicotines and tar, and also alcoholating agents and alcohol. Human papillomavirus 16, there are 2 strains that affect the most, 16 and 18 strain, right? So presents as non-healing ulcer with irregular margins and raised borders. This is the characteristic feature, that it has irregular margins and also raised borders. Leukoplakia, which is white patch, and erythroplakia are precursor regions, that is red patch. You can see here it is leukoplakia, white patch, and there is also called erythroplakia. These are the precursor lesions for squamous cell carcinoma, right? So let's go to the sialolithiasis. Sialolithiasis is actually the formation of a stone in major salivary glands like parotid, submandibular, or sublingual, as you can see in here. So these are the stones. Here you can see the outpouching of the skin in here, right, in the buccal mucosa, and that occurs in parotid in the most common case, and submandibular and sublingual cases. It is associated with salivary stasis, example dehydration or trauma. So salivary fluid cannot get out, and it gets oversaturated with proteins, right? So that oversaturation is leading to salivary stasis, and that will lead to the formation of stones, just like cholelithiasis. That is the reason. And also just like renal calculus, it presents as recurrent or periprandial pain. Or preprandial pain means before eating anything, and periprandial is the surrounding of eating anything, and so eating in affected gland, right? So what is sialidinitis? Sialidinitis is inflammation of salivary gland due to obstruction, infection, example Staphylococcus aureus, mumps virus. This is the most common virus causing sialidinitis. You have to remember this, or immune mediated mechanisms like Sjogren's syndrome, right? So in salivary gland tumors, there are different types of tumors, but we have to remember specific versions of them, and those include pleomorphic adenoma and Warthin tumor. These 2 tumors we have to remember at any cost. pleomorphic adenoma and Warthin tumor. So salivary gland tumor, it usually begins, it is usually benign and most commonly affects the parotid gland, right? So Warthin tumor is exclusively the tumor of parotid gland too. And also submandibular gland, sublingual and mandibular gland tumors are more likely to be malignant. So the more the size is, like if the size of the gland is larger, it is most probably a benign tumor in case of salivary glands, right? So it typically presents as a painless mass, swelling, facial paralysis or pain suggests malignant involvement. That is what it is. And in pleomorphic adenoma, like benign mixed tumor, this is the most common salivary gland tumor. Most common salivary gland tumor, as you can see here, the findings. Most common salivary gland tumor is pleomorphic adenoma, and it is composed of chondromyxoid stroma and epithelium and recurs if incompletely excised, or excised means resected, 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 or ruptured intraoperatively, because there is a high chance of metastasis if it is ruptured, and it may undergo malignant transformation, right? So Warthin tumor, which is also known as papillary cystadenoma lymphomatosum, it is also a benign cystic tumor with germinal centers. You can remember in here, germinal centers are there. It may be a case of bilateral or multifocal, and also it is typically found in people who smoke. So warriors from Germany love smoking. You can remember like that. Warriors from Germany love smoking. So Warthin tumor had germ cell tumors as in Germany, and love smoking means smoking is typically associated with this Warthin tumor. And mucoepidermal carcinoma, this is most common malignant tumor. Mucinous and squamous components are present. So that is what it is. What is achalasia? Let's go further down to our gastrointestinal system. Achalasia, that is causing dilated esophagus as in here. Achalasia is the sphincter or contraction, like extensive contraction of lower esophageal tone in here. Lower esophageal sphincter. Failure of lower esophageal sphincter to relax due to degeneration of inhibitory neurons containing nitric oxide and VIP in the mesenteric or back plexus of the esophageal valve. That is how it occurs. Failure of LES, lower esophageal tone. And primary idiopathic, secondary from Chagas disease, that is caused by Trypanosoma cruzi infection or extraesophageal malignancies, mass effect or paraneoplastic syndromes are there. So Chagas disease can cause achalasia, that you have to remember. CHA for Chagas, achalasia is CHA chalasia. So it presents with progressive dysphagia, which is difficulty in swallowing, to solids and liquids versus obstruction, that is primarily solids. But so in obstructive cases, there is dysphagia to solids only, right? So but in achalasia cases, there is a dysphagia to both solids and liquids. And it is associated with an increased risk of esophageal cancer. Manometry findings include uncoordinated or absent peristalsis with increased LES resting pressure. Barium swallow shows dilated esophagus with areas of stenosis, that is Bord's beak appearance. You have to remember this. This is very high yield point, Bord's beak appearance. So you can see this is the case of Bord's beak appearance in here. So the treatment is surgery, endoscopic procedures, example botulinum toxin injection can treat this patient. Botulinum toxin, you can remember this, you have to remember this. Botulinum toxin injection can treat the patient with achalasia. Okay, the characteristic finding in barium swallow or barium enema is Bord's beak appearance, right? So you have to remember that. What are the other esophageal pathologies? The most common is gastroesophageal reflux disease, and then there is esophagitis, and then there are other symptoms are presenting diseases like Plummer-Vinson syndrome, Mallory-Wistier. We'll talk about these each of these letter by letter, line by line, right? So what happens in gastroesophageal reflux disease is that there is transient decrease in LES tone. Here is the overstimulation of LES tone, and there is failure to relax, but it is a failure to contract transiently. So it commonly presents as heartburn, regurgitation, or dysphagia because gastric acidic contents are getting refluxed back to the esophagus, right? So it may also present as chronic cough, hoarseness as in laryngopharyngeal reflux, and associated with asthma. Complications include erosive esophagitis, strictures, and Barrett esophagus, right? So we'll talk about Barrett esophagus too. And in esophagitis, inflammation of esophageal mucosa is esophagitis. It presents with adenosphagia, which is painful swelling, and with or without dysphagia, which is difficulty swelling. It can occur dysphagia, that is difficulty swelling with painful swelling, or difficulty swelling without painful swelling. Okay, the types are reflux esophagitis, which is due to also erosive. Most common type is that it is secondary to GERD. Reflux is esophagitis is secondary to GERD, that is gastroesophageal reflux disease, and medication-induced esophagitis is in bisphosphonates, tetracyclines, NSAIDs, ferrous sulfate, and potassium chloride. And also eosinophilic esophagitis is in chronic immune-mediated eosinophil predominant cases. It is associated with atopic disorders as in asthma, esophageal rings, and linear furrows on endoscopy. So chronic immune-mediated eosinophil predominant, right? So in infectious esophagitis, there is candida, which is most common. White pseudomembranes are there, and in HSV1, you can see these pseudomembranes in here. These all are due to candida albicans. And then HSV1, human syncytial virus 1, which causes Pons-Stout ulcers. You have to remember this very high yield point in here. Pons-Stout ulcers. And CMV, cytomegalovirus, causes linear ulcers associated with immunosuppression. Corrosive esophagitis is secondary to caustic ingestion, right? So Pons-Stout defects. Pons-Stout ulcers are present in HSV1, while linear ulcers are present in CMV. So let's go to the Plummer-Vinson syndrome. Plummer-Vinson syndrome, it is a triad of dysphagia, iron deficiency, anemia, and esophageal webs. You have to remember this. Dysphagia, iron deficiency, anemia, and esophageal webs. This is a triad. Plummer-Vinson syndrome. Dysphagia, difficulty in swallowing, IDA, iron deficiency, anemia, and then esophageal webs, right? So it will increase the risk of esophageal squamous cell carcinoma, that is Plummer dies. It may be associated with gastritis also. Mallory Wistier. This is very important, very high yield point for USMLE first aid step 1. You have to remember this at any cost. It is a partial thickness or longitudinal lacerations. This is what you have to remember. LL. Mallory has 2L. Those 2L signifies longitudinal lacerations of gastroesophageal junction confined to mucosa, submucosa due to severe vomiting. Often presents with hematemesis, positive with or without abdominal and back pain. It is usually found in patients with alcohol use disorder and also bulimia nervosa. It can occur in those patients, right? So in esophageal varices, what it is the dilated submucosal veins, red in arrows, in lower 1/3 of esophagus secondary to portal hypertension. You can look at this figure, right? You can look at this figure. So what does it show? It shows a dilated submucosal veins, and it is most commonly present in cirrhosis, maybe source of life-threatening hematemesis can occur. So in distal esophageal spasm is another disease, formerly called diffuse esophageal spasm because it occurs almost entirely to the walls of esophagus, right? So spontaneous, non-peristaltic, uncoordinated contractions of esophagus with normal LES pressure is distal esophageal spasm. It presents with dysphagia and angina-like chest pain, barium swallow may reveal corkscrew esophagus. Manometry is diagnostic. Treatment includes nitrates and CCBs, right? So corkscrew esophagus is the characteristic feature of distal esophageal spasm, as you can see. And the other disease we have in here is scleroderma esophageal involvement. So It is the case that esophageal smooth muscle cell hypertrophy and fibrosis occurs that will lead to the decrease in pressure and dilated esophageal dysmotility, that will lead to increase in acid reflux and dysphagia, that will lead to stricture Barrett esophagus and aspiration, and also part of Crest syndrome. And in esophageal perforation cases, most commonly iatrogenic following esophageal instrumentation is there. Most commonly iatrogenic following esophageal instrumentation are there. And non-iatrogenic causes include spontaneous rupture, foreign body ingestion, trauma, malignancy, right? So you have to remember like that. And in pseudomediastinum, you can see in the figure in here, these arrows. In pseudomediastinum and subcutaneous emphysema, signs include crepitus in the neck region or chest wall that can indicate dissecting air. This is near to the neck region, right? This MRI is near to the neck region. Here you can see in the figure. And also subcutaneous emphysema are present, obviously. And pneumodiastinum arrows in C, and subcutaneous emphysema signs include crepitus in neck region or chest wall can indicate dissecting air, right? So another one here is Burhap syndrome. Burhap syndrome is transmitted usually distal to esophageal rupture due to violent stressing that can occur. Okay, that is the common sense we have to do. So here we talk about Barrett esophagus. Barrett esophagus is specialized intestinal metaplasia by replacement of non-keratinized stratified squamous epithelium with intentional epithelium, that is non-ciliated columnar with goblet cells. So in distal esophagus, intestinal epithelium, non-ciliated columnar with goblet cells, arrows in B in distal esophagus. So due to chronic gastroesophageal reflux disease GERD associated with increased risk of esophageal adenocarcinoma is there. Okay, so esophagus, it is lower esophageal sphincter contraction and squamocolumnar junction SCJ or Z line is there. So that is how we see, right? This is Barrett's esophagus case. Red velvety appearance is there, and also there are different types in Barrett's esophagus. So here you can see distal esophagus histology, replacement of non-keratinized stratified squamous epithelium. Here you can see. So let's talk about esophageal cancer. Typically presents with progressive dysphagia. Progressive dysphagia, that is first solids, then liquids, and weight loss, right? So aggressive course due to lack of serosa in esophageal wall, allowing rapid extension is there. Poor prognosis is due to advanced disease of presentation. Poor prognosis of esophageal cancer is due to advanced disease at presentation. So cancer, squamous cell carcinoma and adenocarcinoma, these two are the main things we have to remember in here in esophageal carcinoma: squamous cell carcinoma and then adenocarcinoma. Squamous cell carcinoma usually occurs in upper to third region, and it requires, the risk factor here is alcohol, hot liquids, caustic strictures, and then smoking, achalasia, nitrosamine rich food, and and in adenocarcinoma, there is a part of esophagus affected, which is lower 1/3, right? In the risk factors, chronic GERD, Barrett esophagus, obesity, tobacco smoking are there, and this is most common in America. So basically A for adenocarcinoma, A for America is the case. And let's talk about gastritis. In gastritis, we'll talk about acute gastritis, chronic gastritis. That is it. There are two types of chronic gastritis: as pylori induced and autoimmune disease. And also we'll talk about Mentrier disease and then gastric cancer. Okay, let's go. And in acute gastritis, erosions can be due to what can cause the erosions. The erosions can be due to NSAIDs, which is deficiency. Like this outcast. Sorry, I am stuttering. This outcasts what the defensive mechanisms of our region, right? So defensive mechanism of our gut is outcasted by these offensive mechanisms like NSAIDs, bonds is in Carling ulcer, and also brain injury is in Cushing ulcer. That will decrease PGE2, and that will decrease gastric mucosa production. And in bonds there is Carling ulcer, bond by Carling iron, you can remember like that. In that case it causes hypovolemia due to mucosal ischemia. And in brain injury, Cushing ulcer, that is that it increases vagal stimulation, and that will increase ACS, increase H plus production. So it is always cushion in the brain. So cushion injury is always cushion in the brain, right? You have to remember like that. And in chronic gastritis, mucosal inflammation often leading to atrophy, that is hypochlorhydria, led to the hypergastrinemia, and also intestinal metaplasia, that will increase the risk of gastric cancer occurs, right? So there are two types, H. pylori associated and autoimmune. H. pylori associated is the most common cause of chronic gastritis. It's increased risk of peptic ulcer disease and also mild lymphoma. It affects antrum first and spreads to the body of stomach, right? So in autoimmune diseases, autoantibodies T cell induced to hydrogen potassium ATPase on parietal cells and two intrinsic factor, and also increase in risk of pernicious anemia. It affects body fundus of stomach, right? So let's go to the Menetrier disease or Mentrier disease. This is a very important disease you have to remember. And in this disease, what actually happens is the hyperplasia of gastric mucosa occurs, that is hypertrophied rugae, wavy like brain gyri are present, as you can see in here. Wavy like brain gyri are present, and it causes what does it cause? It causes excess mucus production with resultant protein loss and partial cell atrophy with decrease in acid production. That is what happens. Excess mucus production with resultant protein loss and parietal cell atrophy. That is what it occurs, and it is precancerous lesion. It presents with wave again. Weight loss, anorexia, vomiting, epigastric pain, edema due to protein loss pronounced as wave. Right? So wavy like structure is there in histology, is in brain gyri, right? So in gastric cancer, the most common gastric cancer is adenocarcinoma, then lymphoma, then GI stromal tumor. Common mutations include KIT or PDGFRA carcinoid. Early, we'll talk about early aggressive local spread with node or liver metastasis can occur, right? So this is the way of metastasis. This is the root of metastasis. It often presents with late symptoms, as in weight loss, early satiety, abdominal pain, obstruction, and in some cases acanthosis nigricans can occur. Or also lesser Trelat sign is present. Lesser Trelat sign. Interstitial. In gastric cancer, there are two types of gastric cancers. In histopathology, that is interstitial types and then diffuse types. And in interstitial types, intestinal types, right, there is associated H. pylori, nitrosamines, smoked foods common in East Asian cultures or countries, and also tobacco smoking, ocular hydria, chronic gastritis, commonly on lesser curvature, looks like ulcer with raised margins, right? So that is how it occurs. And in diffuse case, it is not associated with H. pylori, and most cases are due to E-cadherin mutation. Signet ring cells, mucin filled cells with peripheral nuclei. Figure A, we will talk about that. And a stomach slightly grossly thickened and leathery, linitis plastica, you can see, right? So E-cadherin mutation is present in the diffuse type of gastric cancer. So what is Burkitt node? Burkitt node is the involvement of left supraclavicular node by metastasis from the stomach. Okay, from the metastasis from the stomach, there we should like it is the involvement of left supraclavicular node, right? So in Krockenberg tumor, what actually happens is metastasis to ovaries occur, typically bilateral, and abundant mucin secreting signet ring cells are present in there. And in Sister Mary Joseph nodule, there is subcutaneous periumbilical metastasis that can be removed, that must be removed in these cases. Bloomer surface, that a palpable mass on digital rectal exam suggests metastasis to rectouterine pods of the glass, right? So let's go to the peptic ulcer disease. Peptic ulcer disease, there are two types of peptic ulcer disease. One of them is gastric ulcer, then the other is duodenal ulcer. Pain. The pain of gastric ulcer can be greater with meals and weight loss, decreases with meals or weight loss in duodenal ulcer, and it increases like H. pylori infection is present in 70% of gastric ulcer cases and 90% of duodenal ulcer cases. And the mechanism is that decrease in mucosal protection against gastric acid, that is also decrease in mucosal protection or increase in gastric acid secretion occurs. So the other causes include annotations. Here you can see Zollinger-Ellison syndrome, and risk of carcinoma is increased biopsy margins to the rule out malignancy, and generally benign, not routinely biopsy is done in duodenal ulcer. There are complications of ulcer. The main complications is hemorrhage, obstruction, and perforation. These three main complications you have to remember at any cost: hemorrhage, obstruction, and perforation. That is HOP. You should not forget this at any cost. So hemorrhage, gastric or duodenal, that is posterior greater than anterior, it is most common complication. The most common complication of ulcer management is that it is traveling, right? So posterior greater than anterior, most common complication, and then the blood is traveling throughout the body, or it is a case of overflow. So rupture gastric ulcer on lesser curvature of stomach, it starts bleeding from left gastric artery, and ulcer on the posterior wall of duodenum, bleeding from gastroduodenal artery occurs. And in obstruction cases, there are pyloric channel and duodenal, and in perforation cases, duodenal, anterior greater than posterior is in there. So anterior duodenal ulcers can perforate into the anterior abdominal cavity, potentially leading to pneumoperitoneum. Messy, fresh air under diaphragm, pneumoperitoneum, with referred pain to the shoulder via irritation of phrenic nerve. Okay. So acute gastrointestinal bleeding, there are two types of acute gastrointestinal bleeding. One is upper GI bleeding and another one is lower GI bleeding. And in upper GI bleeding, it originates proximal to the ligament of Treves. Ligament of Treves is the suspensory ligament of duodenum. You can see in here. This here is the suspensory ligament. It usually presents with hematemesis or melena. It is associated with peptic ulcer disease and varicose hemorrhage, right? So in lower GI bleeding, originates distal to ligament of Treves, and then usually presents with hematogasia, and also associated with IVT, diverticulitis, angiodysplasia, hemorrhoids, and fissure and cancer. That is how acute gastrointestinal bleeding occurs. Okay. Malabsorption syndromes. This is a very large topic. Malabsorption syndrome. Let's go to the malabsorption syndrome, which we will make the last topic of our today's discussion, because overflow and overload is a very much training thing. So we have to be we have to do the things, we have to read and study the things time and again, but with control, right? So too much is also harmful, too less is also harmful. So malabsorption syndrome can cause diarrhea, steatorrhea, weight loss, weakness, vitamin and mineral deficiencies due to decrease in absorption, and screen for fecal fat, that is Sudan stain, is done. Screening for fecal fat is due to by Sudan stain. So celiac disease, it is also called gluten sensitive enteropathy, celiac sprue, and autoimmune mediated intolerance of gliadin, that is gluten protein found in wheat, barley, rye, etc. and also associated with HLEDQ2, HLEDQ8, 188 to much gluten at dairy open, right? So primarily affects distal duodenum and slash or proximal jejunum, which causes malabsorption and steatorrhea. The treatment is gluten-free diet, right? So what are the comments in this disease? The comments are that this is associated with dermatitis herpetiformis, and it will lead to decrease in bone density, iron deficiency, anemia, and moderately increased risk of malignancy. Example, T-cell hypokalemia occurs. T-cell lymphoma occurs. And P-xylose test is abnormal, and also serology positive IgA anti-TFC transglutaminase, IgA, GTG, anti-indomycel, and anti-deamidated gliadin peptide antibodies are also present in there in serology. So it's almost midnight in here. What time it is in your place, guys? So let's communicate a bit too, right? So in histology, loss of villi, mucosal atrophy, crypt hyperplasia occurs. There is intraepithelial lymphocytes present. So another one here is lactose intolerance due to lactase deficiency. Normal appearing villi except when secondary to injury at tips of villi, example viral enteritis, osmotic diarrhea, decrease in stool pH due to colonic bacteria ferment lactose, right? So that is what it occurs. There is decrease in stool pH. The lactose hydrogen based test is also done, which is used for lactose malabsorption if post-lactose breath hydrogen value increases greater than 20 ppm compared to the baseline. The other one is pancreatic insufficiency. Pancreatic insufficiency due to chronic pancreatitis, cystic fibrosis, obstructing cancer causes malabsorption of fat and fat-soluble vitamins like ADIC and also vitamin B12. It will lead to decrease in bicarbonate, duodenal bicarbonate, and increase in pH, like pH and fecal elastase, right? So D-xylose test is also normal test. D-xylose test is a normal test. So tropical sprue is the other case. Tropical sprue is that similar findings as celiac sprue affects the small bowel. That is the only difference, but responds to antibiotics, and it also responds to antibiotics. Tropical sprue responds to antibiotics, but celiac disease does not respond to antibiotics, right? So cause is unknown, but seen in residents of recent visitors to tropics, right? So comment for this disease is that there is decrease in mucosal absorption affecting duodenum, jejunum, but can involve ileum with time, right? So associated with megaloblastic anemia due to folate deficiency and vitamin B12 deficiency. So that is what attack occurs in is a tropical sprue. The another disease here is Whipple disease, which is very important. Whipple disease, it is due to infection of Tropherema whipplei. It is an intracellular gram-positive bacteria, PAS positive, which is and also foamy macrophages in intestinal lamina propria are there. Right, so the cardiac symptoms, arthralgias, and neurological symptoms are common. Diarrhea or steatorrhea occur later in disease course, most common in older males, right? So the comment is that PS, the foamy whipped cream in a can. Okay, that is how much we do today, because we cannot afford to be drained, right? So thank you so much if you are staying with me until now, and also don't forget to subscribe and check out our recent videos. Thank you.